Hello, in this video, let us look at this condition, polycystic kidney disease. So, this is a problem with the kidney. What is the problem? There are cysts in the kidney. Poly, that means many cysts in the kidney. So, it is also called as PKD, polycystic kidney disease. So, you can see here there is a kidney which is full of cysts. So this is an autosomal dominant condition. Remember, dominant, that means even if one parent has it, that the children can get. So you can see here just the father has it, and here the boy or a girl child, doesn't matter. If they get a single gene from the parent, then they get affected. Okay. So guys, this disease has many forms. Okay. So two forms mainly you remember. The adult one here, you can see there are many cysts here. This is the adult dominant polycystic kidney disease. This is the dominant condition. There is one more condition which is infantile type. Infantile type is actually recessive, looks like. Okay. So here we will focus on the adult dominant polycystic kidney disease. Okay. And in that there are 1 and 2. If it is 1 and 2, what genes are affected, you'll see. In one, it is PKD1 gene which is mutated, which is actually on the chromosome 16. And if it is ADPKD2, then the PKD2 on the chromosome 4 is affected. Okay. Chromosome 16, chromosome 4, 4 4s are 16, something like that you can remember. There are two types in the adult variety itself. Okay. So now let us move on to the clinical features of polycystic kidney disease. So they'll have abnormal kidneys at birth, okay, but symptoms will appear only from 30 to 50 years. So now let us look at a patient who has come to us. So here you can see that this patient is 33-year-old male, okay, and recently he has come to us. 33-year-old male, you can see here. He has recently come to us with hypertension. What has he come with? History, hypertension for evaluation. Hypertension, his blood pressure 180 by 100. And he gives a history that his mother is on dialysis. Okay. So she has some kidney issue. So when ultrasound abdomen of this person was done, so you can see that in the liver, what happens in the liver? Liver also has some small cysts. Gallbladder, pancreas, spleen, no issue. Coming to the kidney, both the kidneys have cysts, they are saying here, and they are well-defined, thin-walled, clear fluid cysts. Multiple cysts are there, and these cysts in the kidney, they vary from 3 to 50 millimeter. That is around 5 centimeter, that big. Just imagine 5 centimeter also cyst is there in this guy. And also in the kidney, what is there? Multiple calculi. Multiple calculi are there in this kidney. Okay, where are the calculi in the kidney? In the calyces. Okay, so now let us understand this. The kidney measurements also they have given. Do you think this is more or less? Just check normal kidney measurement. Anyways, it is enlarged. It's already written here. The kidneys are enlarged. Okay, so now coming to the what are they telling impression? Final impression that they are saying is there is features of adult polycystic kidney disease. So if this is the ADPKD, that is dominant condition, that's what it looks like, because the kidney is full of cysts, thin-walled, multiple cysts on both sides. Okay, not just this, even the liver has cysts. Hepatic cysts are also there. So this is what is there in this guy. Thin-walled cysts everywhere. Okay, this is ultrasound abdomen. And what else did they see? That this guy has a lot of calcial stones. Calculi. In the kidney, what does he have? Calcium. The collecting, you wouldn't say collecting, something like this. You have the kidney structure like this, and from that something like this you'll get, right? The pipe. There you have the stone. Kidney stone here somewhere. This one. So there are multiple calcial calculi. Okay, this is the ultrasound abdomen. So this calyx collects urine before it goes to the bladder. So somewhere here you have the stones. Let me show the stones in black color here. So here you have a stone, here you have a stone, but all of these are non-obstructive. That's what they're telling for this patient. For this patient. Okay. So this person may have palpable kidneys. Okay, because the kidneys are enlarged. He can have pain also, remember. pain in the lumbar regions, that is behind, okay, because kidney is posterior, right? And he can have hypertension. This guy had hypertension, we told you. Family history will be there, remember, because of all this stones and all that. He may have a UTI, urinary tract infection. He can have polyuria, everything to do with urine, you write polyuria, hematuria, that is blood in urine, polyuria, what else, proteinuria. All this they can have. I don't think our patient has all these things. But anyways, all the clinical features we need to list in the exam. Do you know that he can have cysts? Where else? He can have cysts even in the liver. He can have hepatic cysts. He can also have cerebral aneurysm. What is this aneurysm spelling? Aneurysm, right? He can have cerebral aneurysm. So, what and all are the clinical features now did you learn? He can have cysts all over the place. Lot of other places only I will write, okay? He can have cysts in pancreas, spleen, lung, anywhere, okay? So in what and all are the clinical features? Now you tell me. Abnormal kidneys at birth will be there. If you probably do an ultrasound or something, you may find out. But otherwise, symptoms will start appearing 30 to 50. Now our patient is 33-year-old. Remember, he has hypertension. Does he have palpable kidneys? Yes, he has very enlarged palpable kidneys. Does he have pain? Not yet. No, our patient doesn't have pain yet. UTI? No, he doesn't have UTI. Hematuria? No. Yeah, our patient doesn't have at least. Polyuria, proteinuria? No, again, none of these are there in our patient. He's come early, so we will treat him. He has hepatic cysts. Yes, he has cysts in other places. Not sure of lungs, etc. Cerebral aneurysm, we do not know because we have not checked our patient for cerebral aneurysm. So if he has a cerebral aneurysm, poor guy. Now let's see his cerebral aneurysm. We don't know if he has one. He may have one. A cerebral aneurysm, okay, in the brain. So we'll have to check all this, especially if he's going to become a pilot or something, then you have to screen him for all this, okay. So we have 3 more topics left for this, gross morphology, microscopy, and then treatment. Okay, so let's look at gross morphology. Gross morphology, I'm giving you the kidney. What can you see? You can see that the kidney is enlarged. It is symmetric. It's heavy because it's full of fluids, lobulated appearance. Then, what else are you seeing? You can see cysts, very good. And you have multiple cysts which are of varying size, very good. Then, the size can be till 5 centimeter. We have seen it in our own patient, right? Even 5 centimeter. 4 to 5 centimeter also the cyst can be there in diameter, okay. And what is the content of the cyst? Fluid, right? It can be yellow to brown, some fluid, reddish brown it can be, okay. Then these renal pelvis and calyces may be distorted, obviously because of all these cysts. Focus here, guys. Renal pelvis and calyces distorted. And this is a non-communicating, guys. This is a very important point for you to write, okay. So draw diagram in the exam always. So draw 2 kidneys enlarged, and what will you tell? That they have multiple cysts which are non-communicating. Remember, if they communicate, then it becomes hydronephrosis. These cysts are well defined, thin-walled, clear fluid filled. That's what, or the fluid can be yellow to brown anyway. So remember to just say that these are non-communicating cysts. If it is communicating, what is it? If the cysts are communicating, it's hydronephrosis. Remember, now we are talking about polycystic kidney disease where there are non-communicating cysts. Okay. Very good. So what is the next topic now? Microscopy. So microscopically also you will see cysts. Cysts arise from all parts of nephron. Okay, so nephron is there. No, from there all cysts will arise. So draw one nephron and we'll just try to understand. So the nephron is something like this. I'm drawing. It's a long time since I drew a nephron. So I'm just drawing something like this. And from all parts of the nephron, you have cysts arising. Okay. So it can arise from here, from here, from here, from anywhere. So if it rises from this, wherever you have this glomerulus, right? If there is some glomerular structure here, then you know that it is arising from this Bowman's capsule. Very good. So if the cyst contains some glomerular tufts, then you know that the origin of the cyst is from Bowman's capsule. Very good. While if they have some other type of epithelial lining, then you know that it is coming from this proximal convoluted tubule or the distal tubule, okay, or even from the collecting duct can be, okay. Sometimes between these cysts there can be normal tissue. That's what they're saying. Sometimes between these cysts and all you can have normal tissue, but as this time progresses and all, what will happen between all this, you can get fibrosis, inflammation, pyelonephritis, nephrosclerosis, and all that can happen. Okay, with advancement of age of patient, what can happen? You will have pyelonephritis, all this pus, nephrosclerosis, fibrosis, chronic inflammation, all this can happen. Okay, so that is the microscopy that you will write. And here you can see how the microscopy looks like spokes of wheel. That's what they are saying, like a spokes of wheels. These cysts will look something like this. Okay, and here you can see some glomerular structures also. Glomeruli you can see here, right? Can you see? This is a glomeruli, something dark, round, you can see, right? They are reduced in number, they are saying, but it is there, okay, in this diagram. So guys, when you come to clinical features, just talk about some lab tests that you will do. Okay, you will have to talk about GFR, glomerular filtration rate. It will be less, right? That's why these people can go into kidney failure, right? Okay, so glomerular filtration rate you check, then you check urea, creatinine. All these things may show you how the kidney is functioning, and soon they will go into what? Kidney failure they can go into. So in our patient whom we have met, the 33-year-old guy, let us check what has happened to his urea creatinine. I don't think GFR was done for our patient, but serum urea is 24. Urea is fine. But if you look at creatinine, here you can see serum creatinine, it's almost border. So he may be going into kidney failure. And microalbuminuria, he's losing protein, right? So microalbuminuria is there, okay? 89.2, which is very high. Coming to the urine, they have checked proteinuria and traces are there, okay? So he's having proteinuria. Not significant, looks like traces are there, okay? One good thing is he doesn't have hematuria. I already told you, right? This guy is not having hematuria. GFR has not been checked for our patient, guys. Okay, guys, so now let's move on to the treatment of polycystic kidney disease, okay? Main drug that you have to write is TOLVAPTAN, that is a vasopressin antagonist, okay? And for other things like hypertension, you will give ACE inhibitors, ARBs, okay? Tell him to drink a lot of water. If he has kidney stones, nephrolithiasis, treat that. If he has a UTI, treat that. Okay, basically the drug to reduce the damage to the kidney is TOLVAPTAN, and there are other drugs like actually I don't find any other drug here. The only thing is they're saying you should avoid caffeine. It will prevent cyst formation. Okay. So for pain, if they have pain, you give them painkiller. Okay, if they have pain. And what else can you do for these? Remember, this the only drug I'm writing here is TOLVAPTAN. Okay, and for hypertension, you will give what? ACE inhibitors, ARBs. Okay, thank you. We are done with this topic of polycystic kidney disease. Bye bye.